basically not tailored for seniors like you. It's more for myself to relearn my basics and for younger colleagues, but whatever that I have prepared, I'll just put forth in front of you. So this is basics of RD surgery. So first and foremost point for any surgery to start up is to make ports. As we all know that we have three standard ports for pars plana vitrectomy. One is for the infusion, and the other two is for the handle for the light probe and the vitrectomy cutter to go in. So basically what we do is, like, in some situations which I think Anusha madam had already told, like if at all you have a diabetic or any other cases where you need an extra hand for you to support, so you can put a chandelier that will be a 4-port where the light is independent of your maneuvering of your hand, so that you have both hands free for bimanual dissection. As far as the sites are concerned, if a patient is phakic, the usual port is done about 3.5 millimeter from the limbus, and if it's pseudophakic, about 3, and if it's aphakic, maybe 2.5 to 3 mm from the limbus. That's the standard sites where you make the ports and go on with your vitrectomy. Before you go ahead with the vitrectomy per se, you have to always confirm that whether your infusion cannula is properly placed and it's into the vitreous cavity. I'll just replay this video. So the first is the infusion cannula. Two more ports, and I take the light and then depress partially to see whether the end of the infusion cannula is visible. There are certain differences which I would make to what Dr. Anusha had told. She told, like, you do the anterior vitrectomy at the end to make sure that you have completed, but usually we prefer, at least I prefer, to do the anterior vitrectomy and vitrectomy around the ports before you go and do the core vitrectomy or the posterior vitrectomy. The reason behind this, there are possibility that when you are maneuvering the forceps in and out, or your cutter in and out, or your light pipe in and out, you might caught a port side dialysis. The next is, once you have done the anterior and core vitrectomy, obviously the process is you go and attack the posterior hyaloid or the vitreous, the PVD induction. Madam has already covered in detail about it, but anyway, I'll try to do. This is a young patient where the vitreous is very adherent and it doesn't seem to just yield to the suction that I'm giving over there. So in regular cases, you can do as Madam had elegantly demonstrated, but in certain conditions like this where it is very adherent, you can always use a forceps or even a passive suction from a flute can be done. You need to, the classical teaching is you need to have a Fishtax sign or some kind of elevation at that point, then you continue with it. What I generally do is go all around the disc and try to give active suction to my cutter and try to peel it out. If that doesn't happen, then use a forceps, stain with a tricot to identify the posterior hyaloid and then peel it. Even needles can be used sometimes to pick up an edge, and from there you can continue inducing the PVD all through. See, this is basically an RD process that I am doing. So once we are finished with the PVD induction, then you continue with the core vitrectomy and completion of the break localization. So I have identified the break. It's a single HST with a flap over there. So the retina detachment is quite bullous. You intend to do some amount of fluid exchange at this point of time so that the retina goes back a bit, and then you cut the vitreous all around the break and as much as possible anteriorly. The free flap is cut because the vitreous traction is basically at that point. So when you trim it and then continue the vitrectomy anteriorly to the break. The edges are cauterized to make sure that the vitrectomy is completed all around the break. So you don't want any form of or any foci of traction by the vitreous, residual vitreous, which is around the break. So this is what I'm doing right now. So all around the, you can see there is a lattice in that break. So I'm just going and trimming off all the vitreous all around the break and the lattice inclusive. In the process, you might, whatever the retina which is attached might get detached, but that's not a point to worry about. The whole point is to clean the vitreous all around the break and the lattices and free up the complete edge so there's no foci of traction which is left over. Once you have completed the break localization and the vitreous completion, so then we attack the PVR. So sometimes when it's quite bullous and it's free, the retina is very mobile, then you can use a third hand, that's the PFO, the PFCL, which has been placed to stabilize the posterior pole, the disc and the macula. Once you have peeled the PVR from the posterior edge, then you go attack anteriorly and keep on filling the PFCL little by little so that the entire retina, posterior retina is flat and completely stable, and you can attack the anterior vitreous and shave it as much as possible. As Dr. Anusha had said, you can indent and try to peel the entire vitreous up to the base. So identification of a star float is very important, where you can go with a forceps or a needle and nip it up and then peel the, using a pick forceps or an engrafting forceps or a serrated forceps or a max grip forceps, whichever is convenient to you. BBG might sometimes yield, like if you can't find out very flimsy membranes, PVR, which is there on the retina, which is very much adherent, which can cause recurrence, you can always inject BBG in the posterior pole and see that that area is negatively stained and try to pick it up. Epiretinal proliferation should be tackled first and then look into your subretinal gliosis, SRGs, sheet SRGs, or for tractional bands. Then you can either cut it out or peel it out completely. So most commonly they are not accessible, so you make a small retinotomy just above the SRG and then cut it loose. Or if it's too long and too taut and pulling the retina, then you need to pull it in toto or break it up into pieces. So once this is achieved, so your retina is very much mobile now, it's quite supple and retinue get attached completely. The lens process of it is you do an air fluid exchange. First you do a fluid exchange, try to tilt the eye as much as possible so that you avoid a posterior retinotomy. In this you can see it's very, very anterior. Despite that, we could fairly achieve a complete retinal attachment without doing a posterior retinotomy. So basically I've done is tilt the eye a little bit and make it dependent area so that you do the air fluid exchange and completely remove the fluid, and then do the laser photocoagulation all around the break and the lattices. So there are some lattices which are very much seen in the same area. They might be in opposite areas also. So you tend to laser all those areas and make sure that it's well photocoagulated. So choice of tamponade depends upon where is the break and what is the extent of retinal detachment. If it's a superior break, you can very well use gas and get away with it. If it's one-eyed patient or you want the visualization immediately post-operative, it's better to use oil. Oil is also preferable in other conditions like extensive PVR, inferior breaks, complex retinal detachment, or retinal detachment associated with conditions like ARN, PVR, GRT, all these conditions. It's better to use oil where you want a fairly long tamponade to be in situ. Thank you. Any questions or anything? Yes.
Thank you, Rajesh. Can you just quickly mention the settings for peripheral vitrectomy, because I think that's something I missed out on. So the suction and the cutter, how it works, was to avoid peripheral breaks, and interface vitrectomy.
See, the maximum what your machine can give you, the cutting rate, that would be the best. So keep your cutting rate at the maximum and the suction as much as less. So in my machine, which I use Goider, I use a cutting rate of approximately anything more than 3,000 cuts per minute, along with a suction less than 100 when I'm doing a peripheral base shaving. As far as the posterior vitrectomy or the core or the anterior vitrectomy, majority of the situations I keep a suction of about 200. And cutting rate is, you can moderate between, if you want a faster, to surgery to complete where you're not very much worried the retina is completely flat, you can keep a low cutter rate also, maybe around 2,500 to 3,000, and complete it off. Thank you.